Okay, good morning, everyone. Welcome back to Semel Grand Rounds. We will get the presentation started in just a moment. A few quick announcements. As a reminder, you can claim CME credit for viewing this presentation. Please make sure to check your email after the presentation ends, where you'll receive a link to complete a survey to claim your credit. If you don't receive this email, please reach out to Moises Garcia. His contact information is available on semelgrandrounds.com. You can also use the website to find other information on upcoming presentations. Immediately following the presentation, we'll be having a Q&A. If you have any questions, you can either use the Q&A button to submit it during the presentation or during the Q&A session itself. And with that, I will now turn it over to Dr. Asarno to get the morning started.
Hi, good morning, everybody. I am absolutely delighted to be introducing Dr. Donald Meichenbaum. He's one of the founders of cognitive behavior therapy. For those of you who don't know, and I'm hoping that all of you did know that before I said it, in a survey of clinicians, Dr. Meichenbaum was voted one of the 10 most influential psychotherapists of the 20th century, and that's continuing into the 21st. He has received a Lifetime Achievement Award from the Clinical Division of the American Psychological Association, was honorary president of the Canadian Psychological Association, has presented in all of the Canadian provinces and in all 50 states, and internationally, I think just about everywhere. If he hasn't presented there personally, his website has reached them all. He's published extensively and has authored several books, including The Roadmap to Resilience, which he'll be talking about today, and he is made available free for all of us. His most recent article, How to Spot Hype in the Field of Psychotherapy, was chosen as the best article in the field of psychotherapy. And his latest book, Treating Individuals with Addiction Disorders, a strength-based workbook for patients and clinicians, is being published by Routledge Press. I can personally attest to the excellence of his books because his books are some of the few nonfiction materials I can read on the beach. I know Dr. Meichenbaum personally, and it's an absolute delight to introduce him. He was a professor at the University of Waterloo for many years, since his early retirement 25 years ago, when he did not retire at all. Instead, he continued to travel around the country, teaching folks and disseminating cognitive behavioral approaches, his own brand of them, across multiple service settings across the world. He is the director of research at the Melissa Institute for Violence Prevention and the Treatment of Victims of Violence in Miami, where he has developed an outstanding series of workshops. They give grants away. They do all kinds of very important work to prevent violence and the adverse sequelae of violence. Now, on a personal level, Don was my dissertation advisor. He is my mentor and dear friend throughout my entire career. So it's very special to be the person introducing him. He, as I said, he's one of the original founders of CBT with Beck and others who we all know. And we all take CBT for granted, right? It's one of our evidence-based treatments in our toolkits, but it wasn't always that way. So when I was in school, I guess I'm revealing my age, there was psychoanalytic therapy and there was behavioral therapy. And Don Meichenbaum, part of the excitement of working with him, was the founder of this big C in cognitive behavior therapy, which he attributes, like Andrew Cuomo does, to his mother. Don said that his mother always used to talk to herself and taught them to all talk to themselves. And so because of that enormous work, we now target cognitions in our treatments and in the NIMH clinical therapeutics model. Now, the other important feature that I do have to say is that unlike many people and unlike some of the problems we're having with copyrights and other things, Don Meichenbaum is an incredibly generous spirit. He always had the theory of seeding. So what he would say to us in graduate school was the important thing to do was to get thoughts and evidence and science out there and to seed the world so that other people did more work so that the field could grow more than you could ever do it on your own. And I think that his his giving away of the book Roadmap to Resilience for free to help us with this coronavirus pandemic is a good example of that. But he also had long ago, which
Joan, I only got an hour.
Okay, all right. Okay, it's all yours. Go.
Well, thank you. Being introduced by you as one of my top graduate students, dear friend, and moreover that you were a presenter at the Melissa Institute, and they can find online your presentation is just another pleasant aspect of this presentation. First of all, let me thank you for the invitation to present to the group. And let me begin by providing a bit of a backdrop with regard to Joan's comment about the Melissa Institute. 25 years ago, I took early retirement from the University of Waterloo in Ontario and became research director of the Melissa Institute. Melissa was a young lady who grew up in Miami, and she was going to school at Washington University in St. Louis. And a tragic thing happened. She was carjacked on Cinco de Mayo Day and brutally murdered. When such a tragedy like that befalls an individual, a family, friends, a community at large, one of the ways that people cope with trauma, and as you'll see, I'm heavily involved in that topic, is they transform their pain into something good that can come of it. So they created the Melissa Institute, designed to reduce violence and treat victims of violence. Now, the Melissa Institute per se is not a direct hands-on institute of providing services to clients, but apropos of this presentation, it is designed to give science away. So each May, we have an annual conference of which Joan once participated, and all of the material that the Melissa Institute has for these conferences are online. So I invite each of you to visit the Melissa Institute website, www.melissa, M-E-L-I-S-S-A, Institute. And although I'm going to try and squeeze a 5-day workshop into this 1 hour and leave 10 minutes at the end for question and answers, I want you to know that if you go there and on the face page, click on Melissa Institute Resilience Resources, you're going to find 45 papers that document and look at resilience that I have presented on, from high-risk children and their families through adolescents, LGBTQ, human trafficking, to adults in the military, people who have experienced various forms of interpersonal violence. And now that I'm 80 years of age, just about that in another month, I've also focused in on resilience in the elderly. Let me start off by sharing with you one of the presentations that I gave. I was invited by the VA hospital in Miami to give a presentation on the challenging topic of traumatic brain injury in returning soldiers. And I was asked to make a differential diagnosis, help them make a differential diagnosis between returning soldiers who have traumatic brain injury because they've been exposed to improvised explosive devices and PTSD, or the combination therein. Now, in my haste to get through all this material, I'd done a lot of homework to help them appreciate the various indicators. I had an inadvertent faux pas, and I should mention that at the outset of this presentation, because I said to them that one of the challenges in working with these returning soldiers was that they had been exposed to improvised explosive devices, IEDs. Now, in my haste to get through this material, I inadvertently had a Freudian faux pas of, instead of saying IEDs, I kept saying they've been exposed to exploding IUDs. Now, I just kept on, and every once in a while I would hear a snicker, and I figured it was my New York accent. And at the end of the presentation, this chief psychiatric nurse came up to me and said, "Dr. Meichenbaum, can I give you a little feedback on your presentation?" And I said, "I always welcome feedback." And she says, "Well, of all the problems that they confront in combat, least likely is an exploding intrauterine device." And I said, "Well, what are you talking about?" And she said, "You kept saying IUDs instead of IEDs." I said, "No way," okay? And chief psychiatrist looked at me and went, 5 times, okay? I actually told him I have a long-standing problem in this area. I had presented at the Brigham Young University in Salt Lake City. It's a Mormon school, and it's actually the Church of the Latter-day Saints. Instead of calling it the LDS Church, my entire presentation, I called it the LSD Church. I told them that if you're a member of the LSD Church, it changes your outlook and your sense of reality and so forth. So I start off by sharing this anecdote because if you're in the field of treating individuals who have been exposed to trauma and victimizing experiences, one of the things you learn rather quickly is that you can't conduct any kind of treatment for these people unless you have an acronym-based therapy. The entire field of psychotherapy for people who've been victimized is filled with acronyms. So what is it that you do? Oh, I do prolonged exposure, okay? I direct therapy exposure. I do cognitive processing, CPT. What do you do? EMDR. Which finger do you use? Well, it turns out it doesn't make any difference. Oh, what do you do? Stress inoculation training. The moral of this, I'm going to be looking forward to questions, but you cannot use an acronym. So here's the kicker. The kicker is it turns out that when you look at the outcome studies, one acronym therapy is no more effective than any other acronym therapy. In fact, it turns out that the quality and nature of the Therapeutic Alliance, and moreover, getting session by session feedback from the patient, is about 4 times more important than the specific procedure that you use. And in fact, if we look at all of the diverse interventions that have been offered, anecdotal accounts of what helps people, like returning soldiers, for instance, you find accounts that if they swim with the dolphins, if they have a pet, if they go mountain climbing, okay, if they join a group, if they undergo some form of psychotherapy, they're all equally effective. So here's the interesting question. What is it that's common to all those acronyms? What's common to all these activities that leads people to improve as a result? And that takes me to the topic at hand. And the topic at hand is a constructive narrative perspective of what constitutes trauma and resilience. In the aftermath of being victimized in one form or another, even with regard to the present pandemic, one of the things that emerges is that while most people are impacted, 75% of individuals will go on and evidence resilience, the ability to bounce back, to face ongoing adversities and maintain their well-being. And in fact, Tedeschi, Calhoun, and others have indicated that a portion of them may even go on and evidence post-traumatic growth. And when we think of resilience, you shouldn't just think of resilience in an individual. You can think of resilient families. You can consider resilient communities and organizations and the like. So the first question is, if we're going to be of help to the 25% of individuals who get stuck, who evidence PTSD and associated comorbid disorders, who have adjustment problems, what is it that characterizes that group? And moreover, what are the 75% individual doing that we can capitalize on and build into our treatment modality? So to set the stage and try to enter that question, I'm going to share with you what I included in this book called Roadmap to Resilience, okay? Now, as Joan indicated, I have now entered what Erik Erikson calls the generativity phase of life. I have 7 grandchildren and want to make the world a bit safer for all of them. So I have, in fact, written this book and made it available for free. So if you go to roadmaptoresilience.wordpress, W-O-R-D, and the wordpress.com, you will be able to download the entire book. It's sort of written like a mini community. And in that book, I have laid out an algorithm of exactly what you need to do to develop PTSD and an appropriate concurrent kinds of challenges. So God forbid anything bad happens to you or your family, I'm going to give you what I think the literature says puts people and keeps them in the 25% group. And moreover, there is a neurological and psychosocial sequelae of engaging in these behaviors. To begin with, I want each of you to appreciate that you are not only a Homo sapien, but that each of you are what I call a Homo naren. A Homo naren is a storyteller. So essentially what PTSD, as you're going to see, is essentially a disorder of non-recovery. So if we're a storyteller, that means that something bad has happened to you in the past. It may be the recent past, like the pandemic, or it may be a distant past, like exposure to adverse childhood experiences or previous victimization or disasters or grief or losses or what have you. Now, when such bad things happen, you have to tell a story, not only to others, but to yourself. And I'm going to suggest that the nature of the story and the accompanying coping techniques determines whether you're going to be in the 25% group or the 75% group. So let me enumerate in point form, and you'll be able to read more of this on the papers that I have on the Melissa Institute website. That one of the things that becomes important is that you have to have a mindset of being a victim as compared to being a survivor or thriver. That is the nature of the stories that you tell yourself and others. In some sense, you become a poet. That is, language becomes inadequate to describe the amount of distress and the nature of the stressful events that you encounter. So you may say, you know what, I'm really a prisoner of the past. I'm a pariah. Okay, I'm hopeless, I'm helpless, I'm powerless. We can't change. These thoughts just come, these feelings, they just overwhelm me. Now imagine what the impact is on your functioning at various levels if you go around telling yourself on a regular basis that you are a prisoner of the past. Okay? Not only that, these events, as Janet Bullman and others indicate, often violate and shatter your belief system of safety, of trust, of a sense of future. It impacts on how you see yourself, the world, and the future. Keep in mind that to have psychopathology, one of the things that you gotta be able to do if you wanna stay in that 25% group is to ruminate. You have to dwell on it. You have to brood over it. You have to pine over your losses. Not only that, you have to be able to dwell. It would also lead to, you're more likely to have what is called hindsight bias, that you now have information that you didn't have at the time. You tend to engage in contrafactual thinking of if then, only if. Moreover, this all leads you to become more hypervigilant. You tend to ask why questions for which there are no readily acceptable items. You intentionally avoid trying to think about things or avoid events. And unfortunately, that has a boomerang effect of leading to even more intrusive ideation. One of the things that you may do to stay in that group that's important is keep it a secret. Don't share it with anyone. Do not seek social supports or for help. There's longitudinal data by Roxanne Silver and others that indicate that rape victims who have not shared the account, and note the account does not only have to be with the therapist, it may not even be verbal, it may be some kind of expressive notion. The absence of reaching out, of isolating, of loneliness and the like become important ingredients, as well as having a kind of spiritual struggle. As we'll see, that the major way that people in North America cope is to use some form of spirituality. And then finally, it would be helpful if you want to stay in that 25% group, to self-medicate, either by means of using some kind of substances or engaging in high-risk behaviors. All of this is going to lead to your experiencing anger, perhaps, and anger interferes with the processing of stressful emotions. You may, for instance, have a spiritual struggle be angry at God, at the government, political figures. You may get angry with significant others. So what am I saying? I'm saying if we try to look at who gets stuck, who gets into thinking traps with regard to hotspots in their lives, who do not move out, then we could start to enumerate the characteristics of the stories and behaviors. Then what's the contrast? The contrast is to think about what would be all the behaviors that one would do that engages in non-negative thinking, right? So in the Roadmap to Resilience book, as well as the website that's available, I have enumerated 6 domains, fitness areas, that I'll tick off rather quickly. And you can go to the book and look at the more detailed descriptions. In fact, if you get to the website, just go to Appendix A. It enumerates all of the kinds of coping strategies. In fact, Appendix B enumerates all the kinds of problems your clients could have in alphabetical order. You know, from difficulty sleeping to substance abuse to getting along with one's spouse, and you could just click on any one of these. Here's an interesting issue. At a recent conference a couple of years ago, I had a debate with Bessel van der Kolk, who has scholarly put together his book called The Body Keeps Score, where he focuses in on the 25% about the neurological, structural, and functional changes of being exposed to a variety of traumatic events, especially if these are cumulative over time. For example, in terms of the adverse childhood experience study and the like. Here's the interesting portion of that debate. It turns out that the body also keeps score of engaging in resilient engendering behaviors. That there are sequelae of having positive emotions, of finding meaning-making activities, of engaging in social supports. Let me walk you through some of these, and then we can think about what are the treatment implications therein. First, in terms of physical, we know that one of the most important elements to help people be in that 75% group is to get adequate sleep. So if you go to Appendix A and Item 3, it provides a detailed description of ways in which you can improve sleep, address issues of nightmares. There are items there on exercise and its important impact on, for example, in terms of dopamine systems and depression, how you can do self-care and eating appropriately. Then it moves into the whole issue of interpersonal fitness. Having social supports are one of the key building blocks for engaging in some kind of resilient behavior. You have to essentially give to get. If you socially distance yourself, if you isolate yourself, then there are naturally important kinds of consequences. You know, I don't like the notion of social distancing. We're really talking more about physical distancing. So even if you do not have immediate access, we just had Mother's Day, and my kids here in Buffalo live right nearby, and yet we decided not to go over and put ourselves at risk, you know, and therefore we had to do it at a distance in terms of celebrating Mother's Day. But having the perception of social support is as important as actually having the social support. So clearly the degree to which people can maintain social contact by Zoom, as we're doing in this case conference, by Skype, by making donations. Think of all the people coming out at 7 o'clock at night and celebrating the courage and sacrifice of frontline workers. In fact, if you get to the resilience in the elderly, it turns out that loneliness is one of the most important predictors of morbidity and mortality. It's even more important than exercise and smoking behavior. So the degree to which people have a guardian angel, when I look at the research on high-risk children and families, the degree to which there's a buddy system with individuals who are frontline docs and nurses and the like, the degree to which they have a debriefing. You can think of all of that. In fact, if you go to the Melissa Institute website, I had an addendum there on all of the kinds of coping techniques that the doctors, I was asked by various hospitals to come up with some kind of way to be of service to their frontline staff. And that was part of the incentive of giving away the Roadmap to Resilience book. What am I doing? I'm quickly taking you through the variety of fitness areas, coping skills that are been found to put people in the 75% group. So far, I've commented on physical and interpersonal. Let me talk about emotions. Clearly, at this time, with the pandemic, people are experiencing anxiety and depression, frustration and boredom, irritability, anger, and most importantly, grief. In fact, recently in Canada, in Nova Scotia, there was a mass shooting, the largest in ever, of 22 people killed. And in fact, if you go to the website on the Melissa Institute, I have a 90-page handout of a 5-day workshop that I gave on how to help people deal with prolonged and complicated grief that I made available to all the therapists in Nova Scotia. Moreover, if you go to the Appendix A and go down to item 34, you will see that I've included a checklist called Coping with Grief. This was our collection of suggestions by people who have experienced traumatic bereavement. We ask individuals to go through this and to see if there's anything that's on this list suggested by others that they are already using. Is there anything on the list that they think they would add? And most importantly, is there anything they're doing that's not on the list that with their permission we would add? So that you could see that this kind of self-assessment technique can be the basis of a kind of therapeutic intervention. That's item 34, and you're welcome to take a look at that. So one of the things that becomes important with regard to emotions, and there are a whole bunch of sequelae on this, is that how does one handle negative emotions? How do you accept them? How do you tolerate them? How do you name and tame the emotions? How do you educate people about the nature of emotions? There's nothing wrong about, there's nothing debilitating about being depressed or angry or anxious, given the uncertainty of what we're now living through. Those are normal and human kinds of reactions. The key question is, what does the person do with those emotions? Think about emotions as a commodity of something you do with. I stuff them, I drink them away. You know, I act out on them towards others. I try to escape them. So some of the coping techniques that people use to handle emotions is where it's really problematic. And clearly cognitive behavioral and other interventions are designed to help individuals learn more adaptive ways. Not only that, there's increasing data, fMR studies or various scanning studies and so forth, that indicate that engaging in positive emotions of gratitude, forgiveness, compassion, meditation, love, having a sense of awe, engaging in nature therapy, that in doing all of those kinds of activities, that you could build and broaden your emotional base. That, as Fredrickson and others have highlighted, that you can have the cumulative benefits that accrue therein. And on the other side of emotions, the other side of the coin are the nature of the thinking processes. That's what Joan was commenting on about my mother. In fact, there is an interview that is on the Melissa Institute called A Personal Journey of a Psychotherapist and His Mother. I was interviewed to find out who is the origins of cognitive behavior therapy. And, I could do a very scholarly account of all the people from Freud on to Klebsinski to Adler to George Kelly to Ellis, Beck, and so forth. So my answer to the question was my mother. You see, my mother, when my father died, went back to work, and she would come home, and I would eat dinner with my mother each night with my two sisters. My mother would ask, how did the day go? Well, she didn't really pause to hear our answer, but she would then tell how her day went, okay? Now, my mother had a very interesting way of telling her story, because not only would she tell what happened, she would also relate what were her feelings and thoughts during the course of that event. And moreover, she had the knack, since she had a kind of optimistic, future-oriented change talk in her repertoire, to comment on what were effective and ineffective thoughts and feelings, what she could have done that was more adaptive. So I realized that I ate dinner with this woman all my life. So I went to the University of Illinois, where I did my dissertation on how to teach schizophrenics to talk to themselves. I thought they're doing it anyway, so I might as well. Not only that, I then went to Ontario and taught all the people there to do what my mother was doing, whether they were impulsive, angry, experiencing trauma. So I called that cognitive behavior therapy. I don't know what the big deal was. I don't know how I got voted one of the top 10. Not only that, I had the notion about what the field of psychotherapy would have been like if my mother had written Walden 2 instead of B.F. Skinner, where we wasted all those years. Okay, that's an aside. So one of the things that becomes interesting is that you need a mindset that's optimistic, that's hopeful. In fact, one of the major tools that you, the therapist, can use is what is called collaborative goal setting, where you help your clients develop what are called SMART goals: specific, measurable, attainable, relevant, and time limited. It turns out that collaborative goal setting, apropos of C.R. Snyder's work and others, is one of the major ways to nurture hope. And hope and optimism, that dispositional optimism, and it's realistic optimism, it's not just blind optimism, has neurological impact. It affects the nature and structure and function of the brain. Not only that, these resilience engendering behaviors, apropos of the work that's now emerging, can also affect gene expression. Now that's exciting research, okay? So when they study high-risk kids and follow them up over long terms, you could start to see the degree to which people are engaging in this. One way to think about this from a therapeutic point of view is a kind of 2x2 simple box. There are certain stressfuls in your lives, even now in the pandemic time, that are changeable. And then there are other aspects of your functioning that are unchangeable. Now, the other side of the two is that you can have direct action, interventions, problem solving, as Lazarus and Folkman and others have described, or you could use palliative techniques. You could use mindfulness. You could use distraction. You could use your faith. And one of the things that becomes interesting is the degree to which there's a match between which coping technique and which kind of stressor you're dealing with. It was mentioned that I just did a book on addictions, treating individuals with substance abuse and comorbid disorders. And as I wrote that book, I attended a number of 12-step programs, and they always end with the serenity prayer. God, give me the serenity to accept that which is not changeable, and the courage to change that which is changeable, and moreover, the wisdom to know the difference between them. So it's the match between the nature of the stresses. So one of the things that you most likely have are trying to do work at home, and there are children in your home that are constantly interrupting you, other kinds of stresses and the like. If you go to the Melissa Institute website and go on where it says coping with COVID-19, on there are a variety of suggestions on tips for parents, work modeling procedures by Al Kazan and others on how to negotiate these tasks. And that gets us to the last two categories, and then I'll pause. P was for physical, then we had interpersonal, we had emotional, we had cognitive, now we're up to behavioral. That is the degree to which you and your kids can develop some kind of routine, the degree to which you can engage in some kind of exercise, mindfulness, yoga exercises, reaching out, giving to families, to realize that when you wear a mask, not only are you protecting yourself, but you're protecting others, that you're doing this as part of a community. And then finally is spiritual. I had mentioned that that is the most used kind of procedure that people employ in the aftermath of trauma and victimization. Some people engage in what is called a spiritual struggle. They embrace coping techniques, apropos of the work of Pargament and others, where they relinquish interventions to a higher power. Remember, God helps those who help themselves. How do you help people engage in meaning-making activities? Such as developing the Melissa Institute, having the Holocaust Museum. How do you memorialize individuals? Each of these suggestions direct us to have a consideration of the therapeutic implications of this. So once again, I mean, time does not permit me to go through this in detail, but I have enumerated online the core task of therapy, of what makes someone an effective therapist. There are some therapists who are 50% more effective than their colleagues and who have a 50% less dropout rate. So what are these folks doing that makes them get lasting changes in their clients? Let me enumerate those core tasks. And once again, I direct you to go to the Melissa Institute website. So the first thing that these expert therapists do is to develop, establish, and monitor the quality and nature of the Therapeutic Alliance. As I mentioned, that's a much more important ingredient than anything else they can do. They then engage in a kind of psychoeducation, not a lecture, but they use the art of discovery and questioning. They use the art of motivational interviewing. That is, I'm effective as a therapist insofar as my clients see that they have a problem. So I have a set of questions that is boiled down to, how are things now in your life? You see, what I do isn't that complicated. I work with clients to find out how things are right now in their life and how they would like them to be. I ask them next, what have they tried in the past? What's worked, what hasn't, as evident by. Moreover, I ask them, if we work together, and I hope we can, how would we know if we're making progress? What would other people notice? I also ask them, can you envision, can you foresee anything that might get in the way of our making progress in that area? How can we anticipate it? Note that every question I just asked is a how and what question. So one of the things that the therapist who's getting that favorable outcome engages in is the art of questioning, of doing a psychoeducation. I use what is called a clock metaphor to help individuals appreciate the interconnection between their thoughts, their feelings, their behaviors, and their resultant consequences. You know, psychotherapy isn't something sexy. Essentially, what we do as therapists is to listen to people tell stories. So here's the interesting question. What is it about telling their stories to mental health workers that makes them different than going to their beautician, their bartender, their Mother Earth figure in their lives? What is it that I have to offer that makes me worth being paid for to listen to their account? So not only do I listen to their story in a non-judgmental, empathic, compassionate, and in fact, when my wife hears me say this, she says, "Why don't you do any of those things with me?" And I say to her, if you paid me $125 an hour, I would do that with you on a regular basis. So not only do I listen to their stories, I have a way of retelling their story. I say, it sounds to me, and correct me if I'm wrong, there was a set of external or internal triggers, and I reflect back what they've told me, and that they then had at 3 o'clock a kind of feelings, both primary and secondary at the time. And moreover, they had certain thoughts at 6 o'clock, and at 9 o'clock, there were behaviors and resultant consequences. And I say to them, it sounds to me, and correct me if I'm wrong, that this is just a vicious, and I don't finish the sentence, and they usually say cycle or circle. And then we look at the interconnections of how they inadvertently, unwittingly, and perhaps even unknowingly come to exacerbate their situation. So one of the things that becomes interesting is that these therapists have a way of educating clients in an inductive fashion. They have a way of engaging them in collaborative goal setting. They use timelines to get them to attend to where in the past they've done things that are productive. And when they teach skills, they build in generalization. They don't just train and hope. And moreover, they look at an integrative way to address the comorbidity. Once again, I'm rushing right through this. In fact, on June 11th and June 12th, I'll be doing a 2-day full seminar, 12 hours, that each of you could access. And if you're interested, just email me at dhmike, meich@aol.com. Finally, one of the things I'm really proud of is what Joan mentioned, and that is the ability to spot hype. The field of psychotherapy is absolutely filled with bullshit. It really is. And the article that I did with Scott Lillefeld that was chosen by the Contemporary Psychotherapy as the best article includes a 19-item checklist. So one of the things that emerges in spotting hype is that they're exaggerated claims of effectiveness, okay? Whenever they're saying, I'll give you a certificate to take this course, a red light should go off, okay? You can go, in fact, the article is online, and you can see the degree to which people use psychobabble and neurobabble in terms of that their therapy fits all, and that there's little connectivity to the science that underlies it. So, if anything, that which I'm proud of is this kind of checklist. There is a set of studies that came out of Scandinavia called Love Yourself as a Person, but Doubt Yourself as a Therapist. I love this article, and we cite it. And what they did was they studied therapists who got better results. And those therapists who had some self-doubts about the effectiveness of their intervention, who did not characterize themselves as expert, who sought feedback from their clients, they tended to get better results. Those people who were the gurus had much less effectiveness. I hope that this presentation has bolstered your sense of resilience, and that you will make this effort go along. I'm absolutely fascinated by the fact that my Roadmap to Resilience website has been online for a month. And in that time, I've had 14,000 visitors from 95 countries with 55,000 viewings. The internet is unbelievable. And I hope that some way you will help pass that word along. Thank you for your attention and interest, and I look forward to your questions. Hi, Joan.
Hi. I have a question for you from Dr. Miklowitz. Can you comment on the role of mindfulness and acceptance strategies compared to the change-oriented strategies you've described so well?
Both of them are equally effective. There's no winners in the race. So you need to ascertain the client's theories about what's causing their difficulty and what they need to change. So whether you're going to go for mindfulness, acceptance, or whether you're going to go for trying to nurture these people's difficulties in one way has to fit their theory. So for some people, mindfulness may not be an acceptable option. So what will make either therapist effective, the one doing mindfulness or the one doing the interventions I outlined, has to do with the degree to which the therapist creates a trusting, non-judgmental accepting of hearing the people's stories, getting their theory of what needs to be changed. Keep in mind that there's no one acronym. There's no more effectiveness of ACT therapy versus CBT therapist. There's no winner. And the key will be the degree to which each therapist asks for session by session feedback. I'm not advocating one therapeutic procedure over another. That's not where the action is and who's being most effective. I hope that's getting clear. I'm not against either one of these, but if I were a patient, I could never ever do mindfulness. I'm too enamored with my mind to say I should stop thinking. So if you had me lying down, there are people who do workshops where they have people attend and go through quietly into these events. That would be a misnomer for me, okay? Not only that, it would depend on which stressor I'm dealing with. There may be some events that I need to actively engage in direct action. I mean, should I go back to work or not if I work in a meat plant? Do I check in with my fellow workers? Do I try to initiate? If that's the nature of the risk that you're taking, then mindfulness isn't going to be as effective as doing some of these social action techniques. Remember, they're changeable and non-changeable stressors. It's the fit that becomes important. Other questions?
If you were advising the field going forward, what would you see as the most critical new directions to take to advance us beyond where we are?
As a field of psychotherapy?
Or there are many psychiatrists in the audience as well, as a field charged with improving mental health and health in our nation. Let's say you were head of CDC. What would you find?
I'd be isolated, right, if I was head of CDC. Right. Well, I mean, that's a really big question. I guess one of the best things I would do is to make sure that all the psychiatrists, whether they're looking at pharmacological interventions or if they're looking at psychotherapeutic interventions, look at the checklist that we put together on HYPE. Okay, that the most important thing is that we are committed to some kind of evidence-based intervention. Okay. Secondly, I would highlight the data that I think is pretty impressive about the quality and nature of the relationships that people have. I'm sure you've seen on news where they have the emergency docs with the mask on their face and the like, and someone came up with the idea of taking a picture of their face and putting it on the front so that these coronavirus patients get an idea of who the person is behind there. The quality and nature of the attachment of the relationship is what is most important. That's true whether you're giving medications or whether you're conducting some form of psychotherapy. Here's the problem. When they look at expertise in the field of psychotherapy, one of the things that emerges is that those individuals who see themselves as expert in terms of the level of experience and the like does not correlate with outcome. That which improves with experience that emerges is the self-confidence that the therapist has that they're good. Okay? That's the only thing that improves. So it's not just having an intervention, but will the client adhere to it? We wrote a whole book on treatment non-adherence and the high likelihood that clients will discontinue medication. In the book on addiction, 75% of people relapse, 50% drop out of treatment. So therefore, how do you connect with someone so they're going to follow through on anything that you have to offer becomes critical. When we look at skills training, whether it's in dialectical behavior therapy or acceptance or mindfulness, one of the things that becomes very interesting is that you just can't train in hope. And when you go to the Melissa Institute, I have a algorithm, a checklist on what you need to do to increase the likelihood of generalization. Love yourself as a person, but doubt yourself as a therapist. Turned out to be the most important element.
Several questions involved how to access the material, the book, Roadmap to Resilience, and the other materials. And Jonathan very nicely wrote them in the comments, but I want to make sure everybody knows how to access the website. It's roadmaptoresilience.wordpress.com. And I believe it was in the email that was sent around with the
the other thing is all of the papers, the research papers that document my presentation are available on www.melissainstitute.org. Not only that, my email address is dhmeich@aol.com. I'm housebound in Buffalo. It's snowing. Just email me, okay? And I'd be happy to respond to any of your folks with additional questions.
Are there any other questions?
So I guess I hope I've answered your questions and some of your participants. Were there any others that were forthcoming? Do you have anything else that you want to raise, Joan?
Well,
Or Jonathan?
Oh, there's a few more questions.
Somebody-
I think we have 14 or so questions. Are you able to see those, Dr. Sarno? If not, I can ask them too.
No. Okay,
Please.
if you could ask them the last one I had.
So one of the Sure. So Enrico Castillo had asked, could you please describe how you might apply or adapt your approach to building resilience and positive coping strategies for individuals experiencing ongoing extreme hardships in the pandemic, like unemployment, food insecurity, eviction, homelessness, transitions into or out of jails and prisons?
Clearly, some of those challenges that you've indicated have to be done at a community or governmental level. Therapists can direct people to whatever resources are available and helping those people negotiate specific challenges that they're experiencing. With regard to
16 questions.
unemployment, given the pandemic and the uncertainty, one of the things that behooves us is to find out whether they've experienced any kinds of similar struggles in the past. That is, to ascertain what strengths people have that they might be able to bring together. Most importantly, are there social supports? So it's not only telling you, the therapist, but are there significant others in their approach? The degree to which they can in any way be optimistic or hopeful, using whatever skills they have in their repertoire. The degree to which they see these as problems to be solved and as teachable moments. The degree to which they can engage in some kind of positive behavior. It turns out that humor, I put on, when you go to COVID-19, you'll see that I put together a collection of songs, humor, personal sayings, and the like that may give people a little bit of respite in between. I don't want to downplay the challenges of what you've described. You've enumerated everything from unemployment to homelessness to being in high risk and transition behaviors. So the degree to which I can engage the client as a collaborator in problem solving those, so that I, the therapist, am not a surrogate frontal lobe trying to teach people how to negotiate these kinds of challenges, would be the focus of my attention.
Thank you.
Not only that, I would tell them to vote. I don't want to get politically oriented, but I would, and not only vote for the president, but try and mobilize, so think about what's happening at various places where people are coming together as a group in the form of unions or others to raise their concerns, to see if they can get social action and change.
We'll do just one more question. Somebody had asked, what do you think about the Ebola crisis, using survivors versus professionals to help the resilience of others to cope with that situation, compared with professional psychotherapy?
Well, I think any kinds of social supports would be helpful. If you think about the returning soldiers and the way in which they came to support each other, if you think about 12-step programs, and the degree to which peer supports are useful. So you have to be careful about which peers you hook up with that are going to be supportive. So once again, I would clearly use the art of questioning and asking these folks whether they have anyone they've shared their distress with, not only you, the mental health worker. What was helpful or unhelpful? Have there been any occasions when they have helped others? What form have they taken? If they had someone else who was in a similar situation, what advice, if any, would they have? Okay. And then I share with them the roadmap to resilience. I try to address the variety of challenges that people have in that, and both you, the therapist, and the patient may be able to access that and find it of use.
Do we have time for one more question?
Sure.
Sure.
There's one that I'm sorry, I had no ability to see these additional ones. Now I can see them, Jonathan. It's from Gail Wyatt, and she notes that her research has identified ethnic and racial discrimination as a form of therapy that's not included in any of the work that past CBT leaders cite. But many people use CBT when a patient discloses an incident where they were discriminated against. What would you recommend in these cases?
We had John Briere present at the Melissa Institute, and he has addressed the issue of microaggressions due to discriminations. There are two quick responses I'd give. One is, it is absolutely imperative, if therapists are going to be effective, to be both culturally and gender sensitive and developmentally sensitive. And insofar as the therapist enumerates with the client a variety of stresses, especially with minority populations, you need to address the degree to which they've experienced some form of discrimination in the past or on an ongoing basis. So I think that the cognitive behavioral approach that I outlined of the Therapeutic Alliance, being respectful, being trust engendering, trying to do psychoeducation. So the key question is, given what they've experienced and how they've coped, would they want to give it away? Can they make a gift of their experience towards others? And would they give me permission to share that with others? I think that the issue of these microaggressions due to discrimination have been clearly overlooked by the mental health community.
All right. And we're just about at time. I know some people had questions that weren't able to be answered. Dr. Meichenbaum, do you mind repeating your contact information if somebody wanted to get in touch with you?
Sure. It's dhmeich@aol.com. dhmeich@aol.com. And please check out the Melissa Institute. Some of your questions may be addressed in the papers I've written. Once again, thank you very much. And I wish you all to stay safe, be healthy, and hopefully we'll be able to do this again. Thank you once again, Jonathan, for inviting me.
Thank you.
Thank you, Dr. Meichenbaum.